So what does that mean for, we talked about how these were not necessarily designed for physicians or for patients, but it seems to have some implications for physicians and for patients. How do we navigate that? How do we reconcile that tension?
Yeah, it's interesting. I think that years ago, we relied heavily on manufacturers to provide that information, and I'm not going to, I'll call out Bob. I mean, Bob's organization, the NCCN, has done an incredible job of making information readily accessible, even to people like me at a health plan, that's been vetted by experts. I don't know that we need that information directly from a manufacturer anymore. We might need some nuances about safety and drug administration and that kind of thing. That's not coming from a salesperson. But I think there are enough sources of information today that we don't have to rely on the industry for that information.
Well, you've actually raised a different question, which is what level of evidence should the manufacturer share with the physician to help them make a more informed decision about using a new drug?
Bob, that might be a better question for you because I don't see patients.
Well, I think if we stay within the off-label versus on-label sort of scenario, there are a lot of concerns about what level of information should be available. And by that I say that, I mean that if you're talking about a new drug and an on-label indication, there is going to be a fair amount of information there, and there's a lot of reason that the company will have good data and good information, and that's how they got the label. On the other hand, there are uses of those same products off-label for which the level of evidence is every bit as good. So unapproved does not mean unproven. And so you can have levels of evidence that are every bit as good that are off-label. And in fact, I've heard officials from the FDA state recently that there are a number of agents, especially older agents, that are off-patent for which they believe that the current label is inadequate. And that there is data supporting the off-label indications that is at the level and quality that if there was someone who had a vested interest in getting a labeled indication, they could do so. The challenge is with the older drugs that are less expensive, off-patent and so on, that there's really no one that has a strong motive to provide the high-level data that would then support the use of those drugs. So there is a lot of bias here in terms of what agents and for what indications are going to have high levels of information that's even collated and put together and then put forward to the medical community or to the Food and Drug Administration.
So you've raised some interesting considerations because we have a motive gap, we have a label gap. How does this affect patient access?
Well, I can speak for our health plan.
I think that would be helpful.
Yeah.
I would love to learn.
I'll speak for anybody else. And it varies state by state. In our state, we're required to cover FDA-approved drugs, even drugs that are off-label. They would be considered off-label as long as they're listed in a compendium, or the manufacturer or the doctor or physician can produce 2 peer-reviewed articles supporting that use. So I think the fact that this is not on label, at least in our state, hasn't precluded access to a drug. Okay. What precludes access to a drug is non-evidence-based applications. Okay. So I'm not sure that this will change anything, okay. Because at least we've never been in a position to deny access for a therapy simply because it's not in the label. And I think that's where the NCCN has helped level set things, and most health plans today will cover that as long as it's in the compendium, and as will Medicare.
Okay. And I think one of the challenges here is peer-reviewed literature.
Yeah.
And we all know that there's good peer-reviewed literature, and there's awful peer-reviewed literature, and there's everywhere in between.
Yeah.
And so, having a therapy in the peer-reviewed literature does not necessarily mean it's an appropriate therapy, even if that study shows advantage, because it may be poorly conducted, poorly analyzed, not a meaningful endpoint. All kinds of reasons that peer-reviewed literature could be poor, and that's why I think we really do need to look at sort of the totality of evidence, and understand how people who are really expert within that specific domain or
Right.
disease interpret the quality of the peer-reviewed literature.
Having said that, I don't know that anybody's ever used that route to get access to a drug. If it's if they can't find something in the NCCN guidelines to use, they're not trying hard enough. Well, not really, but but I don't know that that's a legislative requirement, but I don't know that it's ever been successfully applied.